Hi, my name is Marianne Byfield from Orlando, Florida, and the other two members of our group are Micaiah Olkowski from Columbia, South Carolina, and Malwina Pomichowska from Detroit, Michigan. Thank you for your interest in the debate regarding whether standardized evidence-based interventions are ethically necessary as it relates to the school systems. Our decision to discuss standardization of evidence-based practice in the school system particularly was because schools are the primary setting in which children with ASD receive their intervention services. I will start with the discussion with a summary of how evidence-based practice is used in ABA. The debate will cover the pros and cons view. We're using an informal structure. Whether evidence-based research is ethically necessary for programs to be used in the school system. Micaiah, or Mike, will present the con agreement. He will summarize research and present illustrations, while Malwina will present research on the pro agreement along with illustrations. We will discuss the ethical implications that may arise in the process. And we'll be discussing what is our role as behavior analysts. So to summarize, what is evidence-based practice and how is it used? Evidence-based practice involves integrating the best evidence along with the professional judgment and what is valuable to a client to come up with a plan to improve an individual's outcome. A behavior analyst starts with the practical question and then looks to the literature for a proven solution. Once a proven procedure seems feasible to help a client, the behavior analyst will use professional judgment to decide how the procedures will require adjustments. The behavior analyst will then adapt a plan for a client, put the plan into place, training individuals involved and monitor data collection to ensure the procedures is effective as possible. Evidence-based started in medicine with adaptations as well. A doctor would prescribe an antibiotic, but then they would talk to the client or the patient to see, what antibiotics will you take? And if they are allergic to penicillin, they wouldn't use penicillin as a choice. Here we have exactly what evidence-based practice should look for. We have the practical question, which is the behavior problem. We look to the best available evidence, and then we talk to the clients and decide what will work for them. From talking to the clients, we then select the treatments, we adapt the treatment for the particular client, we use some more professional judgment, we implement the treatment, and then hopefully what we get is a positive outcome. And we're sticking with our ethical codes as behavior analysts. Next slide. 3 points will be discussed. Point 1, standardization as it relates to clients' rights to most effective individual treatment. Micaiah will start with point 1. Point 2, okay.
The ethical codes that we're going to talk about in point 1 refer to Ethics Code 2.09, Treatment, Intervention, and Efficacy, Ethics Code 4.02, Involving Clients in Planning and Consent, and Ethics Code 4.03. So if we move on, I'm going to begin with point 1, against standardization. Now, currently, there is no organization that determines what intervention a BCBA can or cannot use. However, there are organizations that are involved with making the determination of what intervention is considered evidence-based or not. One such organization is the National Autism Center at the May Institute. They published the National Standards Project Phase 2. Now, what this publication contains is that they did a comprehensive literature review of all the interventions associated with the treatment of autism spectrum disorder, and they analyzed outcomes and the scientific merit of each study and gave each intervention a categorization of established, emerging, or unestablished interventions. Now, if the results of the National Standard Project were to determine what interventions a BCBA could use by limiting those interventions only to those that are categorized as established, this would have a detrimental effect to a BCBA's ability to advocate for effective treatment, receive input from the client about their preferences, and also individualize behavior change programs. So I will begin by looking at Ethics Code 2.09, and specifically on the next slide, we will see a graphic here that shows the components of selecting an intervention in evidence-based practices. As you can see in the Venn diagram, that these three components are research, clinical expertise, and consumer values and preferences. When selecting an intervention, these three should work in conjunction with one another. But by limiting what interventions a BCBA can use only to those that are classified as established interventions, then this elevates the position of research and diminishes the input that the clinical experience and consumer values and preferences has on this process. Now, this is a detrimental process because no individual with ASD is exactly the same. They have unique problems and difficulties, and it requires a unique intervention to address this. This is why, standardized interventions cannot provide a cookie cutter model that can be replicated with any individual. That is why it is critical for clinical expertise and consumer values and preferences to have their say and be considered when selecting an intervention. And standardized interventions also has a detrimental effect when it comes to complying with Ethics Code 4.03, which is individualized behavior change programs. Behavior analysts must tailor behavior change programs to unique behaviors and environmental factors, assessment results, and the goals for each client. Now, this is problematic if BCBAs were limited to only those interventions that were classified as established according to the National Standards Project, for one key reason here. If we go to the next slide, you're going to see a flow chart about the process that the National Autism Center went through when selecting what interventions were included in their literature review. What I've highlighted is the inclusion and exclusion criteria. Now, what studies were not included in the literature review was that they did not look at studies that examined mitigating factors and confounding variables that would lead to those established interventions being successful or unsuccessful. Now, this is particularly detrimental when you think about that there are many comorbid diagnoses that are commonly associated with ASD. Such diagnoses include intellectual disabilities and anxiety. These are just examples, but associated with each of these comorbid diagnoses is specific behavior problems or skill deficits that could potentially render the application of established evidence-based interventions ineffectual. In this process, the BCBA should have the freedom, in light of the comorbid diagnosis present in their clients, to examine these emerging interventions and interventions based in other fields that have resources supported to make the decisions based on their clients' needs and family preferences that's going to lead to the most positive outcome. By limiting what interventions the BCBA can implement only to those that are categorized as established, it limits the BCBA's options when they are not appropriate. The natural environment and schools never present neat problems that can always be addressed by standardized evidence-based interventions. There are a multitude of these different mitigating factors and confounding variables at play. Therefore, a BCBA should have the freedom and has the ethical responsibility associated with that freedom to examine the research concerning the emerging interventions and other interventions based in other fields besides ABA to make a determination of what is best for their client based on the family values and clinical expertise.
Okay, now Malvina will start with the pro argument for standardization, point one.
My first point is in relation to Ethics Code 2.09. Creating standards ensures that every individual within the school system receives evidence-based interventions. The United States Department of Education has indicated that the number of children with ASD served in public schools doubled between 2004 and 2010. And there was a 244% increase of these students in full inclusion classrooms from 1992 to 2006. This data shows that there is a growing population of individuals needing services in a school setting. Standardization will make it easier for practitioners to implement evidence-based interventions because they will have a resource to work from. Not standardizing opens the door for practitioners to use non-evidence-based interventions, which may lead to harmful effects for the clients. Thus, standardization helps prevent the use of harmful procedures, such as the Sunland Miami scandal of 1972. This involved the Sunland Training Center, which was investigated for abuse of its patients under the supervision of a psychologist who claimed to be an expert in behavior modification. Results from the investigation indicated that abuse and misuse of treatment protocols was done by the staff at the facility. Having a standardized protocol for treatment selection may have prevented the staff from utilizing such harmful techniques by being educated on the techniques that have been deemed as well researched and proven to result in positive outcomes. My next points are in relation to Code 4.02 and 4.03. It is the practitioner's responsibility to include clients' input into what interventions are being implemented based on a list of evidence-based interventions. Evidence-based interventions have been tested and retested for efficacy, therefore providing clients with assurance that the treatment has shown to result in positive outcomes. Practitioners also have the ethical responsibility and ability to tailor the evidence-based practices by implementing proper components for individual needs and goals of the client and family. It is the job of the practitioner to determine the best choice of treatment on a case-by-case basis. Standardization does not take this away from the practitioner. It only provides them with a framework to work from. Practitioners working in schools actually have an advantage in making such decisions because they are familiar with contextual variables such as family, school culture, and community influences. As described by Simon, their expert understanding of the local context, systemic variables, and setting demands provides a distinct advantage for effective modification of evidence-based intervention protocols. Their awareness of the key systemic and environmental factors improves their capacity for tailoring interventions to the student's context and selecting treatment modules that are best fits for the student in this setting. Finally, parents are met with confusing and often contradictory messages on how best to help and support their child. Standardization will aid in relieving the stress parents feel by knowing the interventions being implemented have been thoroughly reviewed and determined to show positive outcomes. This will lead to greater approval of treatment by clients. To summarize, with the growing population of individuals needing services within the school setting, creating standards ensures that all students receive evidence-based interventions and prevents use of harmful procedures. Practitioners still involve clients in the selection process and will be able to tailor the evidence-based practices on a case-by-case basis. Practitioners in the school setting will use their expertise on systemic and environmental factors to make such decisions.
Now discussing point 2, standardization as it relates to the ability of the interventions for practitioners and professional freedom. Mike will start with the con argument.
So one of the problems with relying on standards is the significant time it takes in the development of these standards. You know, when the National Autism Center compiled their standards, they did a comprehensive literature review and coding of it that all took time, and that time creates a delay between when new research is published and when they can be compiled in a standardized system. Now, this delay can potentially mean that a client does not have access to the most effective treatment available based on the current research evidence, because the BCBA has to wait until a standardized system approves it and categorizes it as an established intervention. So to illustrate this example, on the next slide, I'm going to talk about functional communication training and how it was represented in the national standards publication. And we're specifically going to look at the timeline of when the national standards were published and when new information about functional communication training was also released as well. So to begin with, the finding and conclusions of the National Standards Phase 2 was published in 2015 and examined research articles published before 2012. Now, in this publication, functional communication training was listed as an emerging intervention and not established. So if a BCBA was limited by standardized interventions that only allowed established interventions to be implemented, then functional communication training would not be appropriate and not be allowed to be used. Now, the finding and conclusions, National Standards Phase 3, will be published in 2021, and they examined research articles published before 2018. Now, the key timeline that we need to look at here is when the National Standards Phase 2 stopped looking at articles and when National Standards Phase 3 will be published. So Phase 2 stopped looking at articles that were published after 2012. Phase 3 will not be published until 2021. In that 9-year gap, new research is going to be published that is relevant to a BCBA's client and in their specific situation. The national standards are evaluating every single intervention that is associated with ASD. Individual researchers look at specific issues in specific contexts and can provide current information, and there shouldn't be a necessity to wait until everything is compiled before a BCBA can act on that knowledge. Because a BCBA is still complying to Ethics Code 1.1, reliance on scientific knowledge, if they are conducting the research and finding the most current information on that topic. To go back to the functional communication training example, Walker et al. Published a meta-analysis examining functional communication and found the intervention was effective to reduce problem behavior and increase the use of augmented and alternative communication devices in schools. Now, this was published in 2018, and this is an example, like I said before, of individual researchers examining a specific issue in a specific context and providing information to BCBAs about whether the intervention is appropriate for their client in their circumstance. Now, as a BCBA, if I had a client in a school system that struggled with behavior problems and communicating, I would have to wait from information that I found that was published in 2018 until new standards were eventually published. In this hypothetical example, that'd be 3 years in 2021. Now, this can have particular detrimental effects when you think about the importance of early intervention and implementing interventions within an early time frame in order to ensure or at least increase the likelihood of the greatest possible outcome for that client. Ignoring these 9 years of new research can have detrimental effects for many students going through the school system. That's almost an entire student's elementary, middle school, and high school careers that they do not have access to the most current and effective treatment. Now, what I propose is a thought process that's illustrated in this next graphic. And what I propose is that a BCBA should definitely start in the center and look at whether established evidence-based interventions would be appropriate for their specific client and their specific environmental circumstance. If the answer to that question is no, a BCBA should not be left with finding the least bad solution from those options. They should have the ability and the freedom to look at these different emerging interventions and seeing if a researcher has published information that specifically applies to their circumstance and shows evidence that the treatment would be effective. I would argue that they should not implement unestablished interventions because not enough is known about those. But in conclusion, this time delay can have a detrimental effect on clients as they are going through the school system, and that BCBA should not have to wait for an organization to compile the standards of every single intervention associated with ASD when researchers are publishing current and relevant information that a BCBA can act on and implement an effective treatment for their client.
And now we have Malwina discussing the argument point 2 for standardization.
Standardization does not mean further research stops. Research on other treatments will continue to be conducted, and the pool of reliable resources will continue to expand. Therefore, more interventions will be added to the evidence-based interventions list to choose from. Initiatives such as the National Standards Project are crucial in this process because the time required to review research would make it functionally impossible for individual practitioners in a school setting to find all relevant articles required to make a determination on whether an intervention is supported by research. There are multiple factors that contribute to this difficulty. One is access to research. Not everyone has access to peer-reviewed publications. And of course, some search engines require a payment. Another is that not all search engines have access to all articles. We've all been in a situation where you thought you found a related article to a project you're working on the BSU library site, but after clicking on it, you find out that BSU does not actually have access to it. There are also limitations based on what keywords or search engines you use. It could be that only or mostly articles with positive effects come up, and those with negative effects are left out or presented pages later. Lastly, if you have freedom to go out and look for related articles, you will have to rely on your professional judgment to make a determination of quality science. The professional will essentially need to conduct a meta-analysis of the available research on the potential intervention, which is very time-consuming. So is this something we can reasonably expect from professionals in a school setting? After all, taking time to evaluate articles and do so appropriately is the reason for the long time delay in the publication of the National Standards Project. My second point is that emerging treatments will not be devalued they will be utilized only after review by experienced professionals for efficacy and benefit to clients. Emerging research often presents readers with conflicting research results that lead to practitioners implementing an intervention that is not evidence-based and would lead to negative outcomes for the clients. A case example is facilitated communication. Facilitated communication was widely promoted by Professor Binklin in the 1990s through his publications claiming that FC could lead to communication unbound. An analysis conducted by the Research Autism Information Service, which is a part of the National Autism Society, looked at over 50 studies published over the years on FC in peer-reviewed journals. Of these 50 studies, 2/3 reported FC to be ineffective in improving communication. Less than 1/3 reported that FC enabled the aid user to communicate more effectively. And then a small number of studies reported adverse effects. The National Autism Center categorized FC as an unestablished intervention for individuals under the age of 22 in the National Standards Project Phase 2. But professionals reviewing this treatment in the 1990s were faced with conflicting articles on the efficacy of FC and may have chosen to implement this intervention for their clients, especially if they faced difficulties in researching or gathering relevant information that I mentioned earlier.
Okay, now discussing point 3, standardization as it relates to the practitioner's ability to implement treatment and resources available in the schools. Mike will start with the argument.
Mm-hmm. And I will be discussing Ethics Code 1.02 and Ethics Code 2.03b consultation specifically. So moving on to the next slide here. ABA does not get conducted in a sterilized, controlled, and experimental environment. There are many different factors that can influence whether a intervention is successful or has negative outcomes. Now, one of these factors is the resources available in the school and the ability of teachers to implement the interventions the way that it was intended. Now, one factor that standards doesn't account for is the fact that teacher buy-in and a sense of shared responsibility is a huge factor when it comes to determining whether they're going to carry out an intervention with high fidelity and lead to a positive outcome for their client. Because if a teacher does not believe in the intervention or its effectiveness and does not have that feeling of shared responsibility, then the likelihood of them implementing the intervention with high fidelity is low. Now, according to Locke et al. 2016, they say that the intervention setting may play a role in the suboptimal implementation of autism evidence-based interventions in schools. Successful implementation may require tailoring implementation strategies to address the intervention setting and adapting aspects of the intervention or a combination of both. And I would argue that tailoring and adapting interventions is a part of the collaboration process between the BCBAs and the teachers that they are consulting with in the school in order to work together to implement an effective treatment for their specific client. Having the teachers involved in that intervention has a strong likelihood of increasing treatment fidelity and ensuring that the intervention is implemented correctly. Now, part of the problem of including other people in this collaboration is that there's the potential for a teacher to introduce an intervention as an idea that is not evidence-based. Now, our textbook written by Broadhead and others actually lay out a model for how we can go about in this situation while still working collaboratively with the teachers and getting buy-in. So one thing is that we can think about, is the proposed treatment have the potential to cause physical harm for the client? What is the magnitude and what is the likelihood of a negative outcome if you implement this treatment? And can the treatment be translated into behavior principles? And what research supports that proposed treatment? Now, a BCBA should make their decision on how to work with the teacher when working collaboratively based off of those questions. Creating a standardized list of interventions that a BCBA is allowed to implement is incompatible with collaboration with the teachers and would not allow BCBAs to go through that process of determining what interventions to use when you're working with people from other fields. If a BCBA is predetermined by the standardized list of what is considered established evidence-based, then they have limited options about what interventions they can implement, and leads to a dogmatic approach where the teacher, instead of collaborating with that process, is dictated to and therefore does not have that sense of shared responsibility that comes from collaborating and in the consulting relationship. I would argue that by sticking to a standardized list, that this is actually detrimental to the client, because ultimately, by creating a hostile consulting relationship, they are decreasing the effectiveness of those established interventions, where greater benefit could have been reached if the teachers and the BCBAs worked together in a collaborative manner and had the freedom and flexibility to choose what interventions to implement and weren't restricted solely by a standardized list.
Okay, now arguing the pro side of point 3.
The solution to inadequate resources available is not to change the interventions, but to increase resources. Standardizing evidence-based interventions will narrow the focus of education that teachers receive during college and professional development provided by their employers and support staff. To support my point, I will reference a study by Stammer et al. Conducted in 2015. The authors examined the extent to which public school teachers implemented 3 evidence-based interventions for students with autism in the way they were designed. The 3 interventions were discrete child training, pivotal response training, and functional routines. Results from this study indicate that procedural fidelity continues to increase through the 2nd year of training. As the authors stated, this suggests the importance of continued practice for extended periods of time. Standardization will improve this through its long-term use. Results also indicate that teachers in public school special education classrooms can learn to implement evidence-based strategies. The authors emphasize that this will require extensive training, coaching, and time to reach and maintain procedural implementation fidelity. Having a standardized protocol for selection can free up the time professionals spend on research and evaluation of treatments, and that time can be allocated towards training and coaching of those specifically implementing the procedures. I would argue that the time spent on training and coaching will enhance the collaborative relationship of professionals. In addition, teachers' perception of the intervention after adequate training will improve teacher buy-in and further result in greater treatment fidelity. Secondly, standardizing evidence-based interventions can lead to greater resources available to practitioners based on a standardized curriculum and protocol guides. For example, the school can budget for potential resources needed for interventions based on the standardized curriculum in their first fiscal year planning procedures, as well as include training procedures during the planning of professional development activities. I think it's important to state that instead of basing your intervention on the available resources, it is more realistic and ethical to attain resources for the best intervention that is likely to produce meaningful outcomes. There are actually many funding streams available to school professionals, such as donorschoice.org. Besides, having resources for any intervention that is not evidence-based does not inform professionals whether that intervention will work or not. And to summarize, teachers can learn to implement evidence-based interventions in a school setting, but will require training, coaching, and time to implement procedures with fidelity. By standardizing the treatment selection process, support professionals such as BCBAs will have more time to collaborate with teachers on trainings, as well as oversight of procedures. In addition, schools will be able to budget for needed resources based on a standardized curriculum.
Finally, we have our question and answer section where Mike will start with question 1.
So question 1 is, how would you explain your ethical responsibility to a parent who wants you to implement an alternative treatment that is not a evidence-based practice? I would start by talking about how myself and the parent have the same goals in mind for the client, and that is for the client to succeed and have access to a lesser restrictive environment and naturally occurring reinforcers. And it is my responsibility as a BCBA to rely on the research and what science has shown us about how to reach those goals that we mutually share for their child. I would argue that and warn against that that the child would struggle, reaching those goals with the alternative treatment, but keep in mind that there is a shared responsibility and evaluate the options available based on the research.
Okay, question 2 is for Malvina to discuss.
The question is, what are some strategies behavior analysts can use to effectively collaborate with professionals from other fields who utilize alternative treatments? BCBAs are ethically obligated to promote the science of behavior analysis in their work, but they are also obligated to operate in best interest of their clients. There may be instances where the best interest of the client means utilizing treatments from other disciplines. Bradhead, in his article, Maintaining Professional Relationships in an Interdisciplinary Setting, Strategies for Navigating Nonverbal Treatment Recommendations for Individuals with Autism, recommended that BCBAs advocate, but only after thorough review of the non-behavioral treatment being used. When collaborating with colleagues from other fields, the goal should be to maintain a professional relationship. In order to do so, it is important that BCBAs promote trust, diversity, interrelatedness, respect, and effective communication between individuals on the interdisciplinary team. These factors can facilitate a positive working relationship between professionals. In addition, team leadership should be shared, with each member focusing on leadership roles that directly relate to their discipline. For example, when implementing an ABA treatment, the BCBA should take the leadership role in this process due to being the expert on the treatment among the team. Similarly for other professions.
Okay, third question. Do you have any personal experiences? I'll be taking that question. There was a study done on the influence of combined gluten-free and casein diet on behavior disorders in children, adolescents diagnosed with autism spectrum, and a 12-month follow-up. The results were there were no significant behavioral changes and no association with urinary beta-casomorphins concentrates were found after gluten-free diet. A 6-month gluten-free diet do not induce significant changes in behavior and no association with urinary beta-casomorphins. The research clearly states that there's not only is that there is no evidence on the diet. My experience was I was working as an ITDS. A mother had a 2-year-old. She canceled an appointment because her child was ill, but stating her child started talking and pointing. Following week, the child was not talking or pointing. So as the ITDS, I probed some questions with the mom, like he was sick, was he not eating? How was he sick? She said, well, no, he hadn't been eating anything. So my professional judgment deducted, well, if the child hadn't been eating, either the child maybe was in ketosis or they have food allergies. She started the gluten-free diet following week, and within 2 weeks' time, the child started pointing and started developing all their skills. Therefore, in that, professional judgment sometimes goes against what hasn't been proven. And I think it's ethical to suggest to not hold parents, to not suggest to do the right thing. So our professional experience, we see things that maybe aren't evidence-based, and that can help our client. And I think that sums up our debate.
Yes, we have our references here. Apologize for the small text. But yes, thank you all for joining us. Another slide, my apologies. And thank you for watching our debate.